Good morning, everyone. If you could all take your seats, please. Right, if I'm on the right time zone, it's 8:34 according to my iPad. So welcome to the first session on in today. I'm not sure if today is day 1 or day 2, because I wasn't here yesterday. So day 2, right? Good morning to you for the first session of day 2. My name's Quentin Sandifer. I'm a strategic advisor to IANPHI, and I'm chairing this morning's session. But before I start, our hosts, represented by Anders, have a short public announcement.
Good morning to all of you. Thanks for a really good day yesterday, and I see a lot of interaction between many people here, and I think that's one of the main points of this meeting, really. But I would like to remind you about the Stockholm Statement that we talked briefly about yesterday. Please read, please comment, and if you, we heard some rumors about some people did not receive it. If you have problems with that, talk to Sarah, and she will see to it that you get a copy of it. So I hope we can all say that we read it carefully tomorrow and we all agree about it. Thanks.
Right, now I believe we've got, this is a hybrid meeting, is that correct? So we'll have people online. So I obviously can't see you, but you can see me. So good morning to everyone, wherever you are. Welcome to this online session. We have a couple of online speakers as well. We have a couple of online speakers as well. So could we just start with the agenda, please, so we can just see what we're going to cover. Is that my first slide? May I have it? How do I advance the slides then? Excellent. Right, well, I'm so close now, I can't see, but I shall just work my way around here, not knock the flowers over. Have I? Ah, right, even better. I've got it. Okay. Great, thank you. Well, I've had the privilege of chairing the executive committee that's overseen this project. This project began at the beginning of the year with the awarding of a grant from the Bill and Melinda Gates Foundation, to whom we're very grateful. And the project properly started in April. And you can see what the purpose of the project is in the first statement. This very much reflects the state of global concern about surveillance and other aspects of the pandemic preparedness and response. And we focused very much on the concept of integrated disease surveillance. What exactly does this mean? And how exactly might we strengthen integrated disease surveillance in order to create greater awareness globally of potential threats to human health and hopefully, therefore, at least prevent, or not prevent, at least mitigate better the effects of another pandemic. And there undoubtedly will be that in the future. So there were 3 work streams. Briefly, we undertook a literature review. We called it a scoping review. And you're going to hear a bit about that in a moment. There had been a Lancet publication in June of last year, which had set out 5 principles for disease surveillance, and we used that as the framework for the scoping review. We conducted a survey of the IANPHI membership. As you know, we're 110 or 111 members or so. How many? 115 now. Excellent. 115 members. I need to update a paper then in that case that I've been working on. 115 members globally, and we got responses from 61 members, which is roughly 60%, which is a pretty good response rate. And can I just say a really big thank you to every institute that took the time to complete that. It was a fairly comprehensive survey. You had to send it out to technical leads in order to achieve that. And then we undertook a number of deep dives. We went to a range of lower middle income countries. We also had a few high income countries. And again, very rich learning, and you'll hear about that. We've also been liaising closely with the Bill and Melinda Gates Foundation, not just the governance of the project, but also to hear about their grants that they had funded. Earlier in the year, the Robert Koch Institute study that was going on in parallel, and also the resolve to save lives. So we go to the next slide, please. This slide, really, it looks busy, but it really understates the sheer scale of the amount of work. And I have to say, as the chair of the committee overseeing this, it has been an extraordinary experience to see members and partners rise to the challenge. This has been an enormous undertaking. And quite frankly, we have given, I believe, personally, a little bit biased, extraordinary return for value for money on the grant that we received. The amount of work we've done, I believe, has truly exceeded the value of the grant, but I'm not making any particular point there. I just want to emphasize the sheer scale and reach of the contributions. Next slide, please. Right now, this is a bit that makes me nervous. This is our agenda, and we've got to wrap up by 10 o'clock. And I can only achieve that, or we can only achieve that, I should say, if everyone sticks to time. So now look, you're all sitting here as if you're about to do an exam in school. So I'm going to treat you like the exam vigilator. You're all in the gymnasium now, studying hard, ready to turn over your papers, and our presenters are going to have to stick to time. I will start signalling, and I will do more than signalling if people start running over. So please, if we all want to get to the end, but more importantly, if we all want a bit of discussion at the end. So we've got, first of all, an introduction from Jean-Claude. So Jean-Claude, please come up, and could you work from that lectern over there, Jean-Claude, please? And then I'll stay here. Oh, I haven't finished my job. Go to the next slide, please. And okay. So just to give you a little bit of a heads up, when we come to the discussion, you'll have heard an awful lot of information. What we would like you to do is, having heard all of that information, is to reflect on your own experiences and offer us some reflections and views on what you've heard. Things about how we could strengthen surveillance, barriers to challenge that you've not heard us mention. Anything else that we should be saying and recommendations that we should be making, and who should take those on. And are there any particular tools or resources? We know that a number of our colleagues, particularly in low and middle income countries, would really like to see some tangible, practical things that they can take from this. I think I've done my introduction. Excellent. Over to you, Jean-Claude.
Thank you, Quentin. Oops. How I move the slides forward? Sorry. Okay, so hello everyone. It's very nice to be here and to see so many people that we could not meet for at least 3 years now. So I will speak about the work stream one very briefly and the survey afterwards. So the work stream on the scoping review, this has the institution and the team that were involved in that was led by Gerd Flodgren. And the systematic scoping review, I won't get into details of methods and concepts and findings, but it was to understand the current state of evidence and approaches to conceptualization and operationalization of ideas within the scientific literature. And the conclusion is pretty easy and very short. It's a fragmented and incomplete evidence of poor quality with little information on ideas. Generally speaking, the most of the information comes from African countries because WHO has been active on that, and also it was limited to outcomes and process, not very much, and no good evaluation in terms of effectiveness, and particularly also in terms of value for money. So the scoping review concluded of a need on good governance, a functional system and structure, and adequate resourcing. And we'll see that in the survey, we basically found the same thing, but based on the current status at the time. Now, so, this is the working group and members of the working group scattered around the world. So we met at least once, sometimes twice a week, and this is the institution that they represent. So it's a very nice network and very active network, and. So in terms of aim, it was to characterize the understanding and development of integrated surveillance. And of course, 110 has been said was targeted as IANPHI members. 65 participated. It was a question of that was online quantitative and qualitative, and we needed a case definition. We always need a case definition anyway. And it was the definition that was used was from the Nsumbuga paper in 2006, a combination of active and passive system using a single infrastructure that gathers information about multiple disease or behaviors of interest. So, and the responses were self-reported, so it might be biased there, but that's the only way we could do that. And we also documented case studies. I won't get into those details, but they are very rich in terms of learning and sharing of experience. So 59% of the respondents responded, or of the targeted population responded, which is pretty good, pretty well balanced by income group country, and a bit heterogeneous by WHO region, which is on the right. Well, yeah, and and also of the 65 who responded, 16 said we have developed integrated disease surveillance. 25%. 36 said we have partially developed integrated disease surveillance, 55%, and 13 said that didn't have any integrated disease surveillance. It would be interesting to go through the details by income group and region, but I don't have the time, and I move to the next one. Oh, okay. And I will try to cover those points before the end of my presentation, which I will go pretty fast about. So, about the concept of integrated disease surveillance, how it is understood, the understanding by IANPHI members differs from country to country, and they insisted on the fact that there's a lack of a definition of ideas that was universally agreed and understood. So, and they said that integration of surveillance tools and institutions is a complex process that involves multiple stakeholders and sectors that occurs at all levels of the health system and should include non-health sectors. The non-health sectors, particularly in the One Health perspective, is very important. And the purpose and function of surveillance, how the systems enables better decision and response to health threat, was a key consideration. That was much more important than the technical dimension of integration. So what was the role of National Public Health Institute? We have to recognize that Ministry of Health played a major role in organizing and structuring that. But when there were National Public Health Institute in countries, they played a major role, particularly on the core function. And this was particularly true for countries in higher income group and those with more developed IDS systems. We have a lot of data to show that, but I won't get into those details as well. And the report is very well documented upon that. So what about data integration? Of course, there was quite a bit of problems in terms of integration between organization, local versus national level, and also of sectors, agricultural, for example, versus human health, and also pretty much quite a bit of fragmentation. And regarding laboratory, integration of laboratory data, mostly from national public health laboratories, which usually does not cover the whole country, particularly in less developed countries. Genomic testing and sequencing predominantly available only for those who had partial or developed IDS systems. So there are quite a lot of national public institutions that didn't have that capacity. And also, participants stressed on, and this is a positive value, the enabling role of technology, including greater automation, electronic reporting system, algorithm, and data platforms. So that's, I think, a very important key message. But the workforce need to have skills in those dimensions. So there was gaps in skills related particularly to data science, analytics, and information technology, but also on public health, also on epidemiology. Respondents with no ideas more likely to report workforce capacity gaps in information technologies and respondents that had more developed ideas. And the surveillance workforce development were led by the Ministry of Health or National Public Health Institute, with no difference by country level, and particularly in those less developed countries, workforce capacity was most based on either on academic institution and external funding, external organization. And so there's a major need to invest in a sustained way in workforce capacity and development. So the governance was a key issue and was pretty well documented in the survey. It will be even better documented in the deep dives. So the Ministry of Health and National Public Health as the leaders, of course, in most settings, but there were limitations in governance with integration barriers at the interfaces. The interfaces between systems, between organizations is a key issue, and that was pretty well documented in the survey, also in the deep dives, as I said. Insufficient adherence to legal mandates. Legal mandates were not perfect, were sometimes could have been worked better, but there was insufficient legal adherence to it. And data protection was also recognized as an issue. About 50% said that it was well established. That means the other one was not so well, or sometimes not established at all. So that's very important in terms of data transparency. And countries with better integrated system, they say, well, we are partially or well integrated. Okay. You went over 3 minutes, so I'll take 1 minute more. I count. Sorry to pull your leg, Quentin. So a better developed IDS system tended to have better governance. So it seems when you engage in integration, you work on governance, which which indicate or suggest a key value here. And there was also a lack in terms of core function, a lack of evaluation and feedback of surveillance. There was 5 core functions that we use, and that one, whatever type of country, was not well covered or insufficiently covered. Of course, financing, there is not enough money for that, and there's resourcing requirement reported in all countries, much more critical, of course, in low-income countries that have less capabilities, less government financing, and much more heavily dependent on external funding. And for low-developed countries, this is one of the key issues if we want to have a sustained development of that strategy. And greater investment and government commitment are needed if we want to move forward to be better prepared and better able to respond and to evaluate the response, public health response in case of threat. So this is, and one of the things that I forgot to mention is that the pandemic was an important opportunity in developing surveillance. In most of the country, I think it was 45, I think they said, we were able to develop in a sustained way our surveillance system beyond COVID. And the other one said, well, it did not last long. It only was done for some time for COVID. And a couple of countries said only it just destroyed what we had before. But so that was an opportunity. And this is my last slide. So in terms of analyzing the key component of effective surveillance, the Oliver Morgan paper, which is short but which is very interesting, was used as a model. So we asked, what do you think about what it is said in that paper? So respondents say, well, we corroborate what it is said in that paper. However, they identified other critical factors: governance, a need for adequate regulatory frameworks. That was something that came out pretty much. And political engagement and appropriate control. You do not need a commitment when there is fire. You need to do it before. And evaluation as well as monitoring. Need for better data management. And the purpose is important, but data management is important to ensure data integrity and confidentiality, interoperability, and equity and guaranteed access to surveillance output, as well as resilience and capacity building, are key issues. Thank you very much for your time. Sorry, Quentin.
Thank you very much, Jean-Claude. And now we're going to have a brief overview from Andrew of the deep dives. Andrew.
Lovely. Good morning, good afternoon, good evening, wherever you might be. My name is Andrew Lee, and I'm from the UK Health Security Agency and the University of Sheffield. And it was my pleasure to be the technical lead on this project. And, when I was invited to do it, I said to Sadaf, who was the director then, if we were doing this as a research study, we would have asked for triple the amount of money, and we would do it over 3 years. But we did it in 6 months for pittance, really. And it was only possible because of the contributions in kind of so many NPHIs around the world, not just in the scoping reviews, but in the surveys and in the deep dives. So I'd like to start with a big word of thanks to all the NPHIs who contributed so much. Can I also start by telling you about the NPHI deep dives? Could I have that slide, please? And the deep dives were basically qualitative studies looking in depth at 7 countries. And what we did was unique again, and it's only unique because it can only be done by IANPHI, was twinning partnerships. These were bilateral partnerships between 2 NPHIs to carry out deep dives in each country. So we had Mozambique, Malawi, Uganda, Pakistan, Sweden, Canada, and England doing deep dives in partnership with a second NPHI to do that task. So you don't want to hear from me. You want to hear from the people who actually did all that hard work on the ground. So at this stage, can I invite, I think it's Valda from Mozambique. Thank you very much.
Good morning. My name is Ivalda Masicam. I'm from Mozambique. We had the opportunity to work with IANPHI into this IDS project, but we also had the opportunity to have a direct funding from the Gates Foundation. So we had 2 works in parallel going on, but it was very good to have both at the same time. So both of them were integrated. We were talking about integration. So In 5 minutes, I will try to summarize the findings and recommendations from Mozambique after this work. These are the current scenario of Mozambique when we are looking at the 5 principles of IDS. In general, Mozambique have currently our community-based mortality surveillance system with a denominator, but this is only for mortality, but not for disease surveillance yet. The lab is well established with the NPHI being the main institution for public health labs. Digital data, we are still moving from paper to electronic based, and we don't have a unique ID in Mozambique that is a challenge. When we're talking about data transparency, there's been a very good experience during the pandemic with this work between the public and the private sector, but it's still a challenge. But we do have a very great opportunity because the INS, the National Institute of Health in Mozambique, has established a National Health Observatory that is a data repository not only for health data, but also for other public health related data such as animal, environmental, etc. And finance is always a challenge for low middle income countries, as everybody knows. So when we asked about the perceptions of integration and during the deep dives, we saw that there are different perceptions and different levels, especially for the national level. The government, they look at data integrated disease surveillance more into our analytical level and in a more systematic or interoperability level. But when we're asked at the health facility and the provincial district level, they look at integration in a more data collection level. So when we discuss planning for IDS, we have to take into consideration all of these perceptions, and it is different from the countries, from different countries. Within the countries also, there's also differences. These are the main challenges and opportunities that we found during the deep dives. The main challenges to implement integrated disease surveillance in Mozambique are mainly there are multiple systems in place, and this is because it's always donor-driven. It depends on each donor's interest. There's no unique ID, as I said, and there's the issue of human resources, right? But we do have many opportunities. The interaction between the public and the NGOs and the private sectors is getting better. We are migrating from paper-based to electronic-based systems, which is a great opportunity. And we also have the National Health Observatory as the data repository. And we see that in our short term, the best way to implement integrated disease surveillance is using this kind of repository. There's the National Health Observatory. And in the more long term, we should definitely look at other levels of integration, such as at the data collection level. So we came up with a preliminary framework of what an IDS should look like for Mozambique in a short term. We should consider definitely the different sources of information from the health facility data, lab data, and the community, not only at the health facility, not only health-related data, but also animal, environmental, financial data. And the National Health Observatory has the main methodology to do IDS in Mozambique. So the main recommendations that came up from this work are definitely involved stakeholders when we are talking about IDS and planning. Invest on healthcare and community workers. It's important not only looking at the systems, but at the people, as we talked about in Berlin, right? Sustainability, we need to leverage existing initiatives and not creating more. And we need always to leverage existing platforms and not to create more silos when we are talking about health, especially health information systems. So this is what I had to present, but we started integrating in a more person level and a more institutional level, because at the National Health Observatory, this is a great opportunity that we have, not only to bring data together, but also to bring people and institutions together in Mozambique. Thank you very much.
Thank you, Evalda, and thank you for keeping exactly to time. Now, the next three presenters are presenting remotely. So I am hoping now that technology is going to work. So first, from Malawi, Dr. Ben Chilima. Good morning. Ben, can you hear us?
Yes, I can hear you very, very well.
Ben, over
Greetings.
to you. 5 minutes, please, if you could. Thank you.
Thank you so much. I hope my presentation will be uploaded from there. Hello? Thank you so much. I am speaking from, actually, I'm sitting in Rwanda. I'm in Kigali, attending another meeting, but I'll present for Malawi. This is Malawi is in Southern Africa, right next to Mozambique. And my sister, congratulations for a nice presentation. Next slide, please. Could I see the next slide? Thank you. I cannot see very well from here. So I think that's the first slide, which shows just the statistics about Malawi, that we are approximately 21 million people, average age 66 years old. On the right in the yellow, what you're seeing is the structure of the Ministry of Health. It is responsible for health in Malawi, whether you're providing through private sector or not. And it is Minister first, then Secretary for Health, then directors, followed by others below. I happen to be one of the directors. Next slide, please. There are many sites which are providing services, and for the sake of this conversation, I thought I should describe that every site has multiple registers where we get data straight from the household, from the community, and so on. There are patient registers, there are other registers purely for drugs, for supplies, and so on. Some of those registers are for specific programs like malaria, TB, and so on. But for IDSR, a large proportion of the data comes from OPD registers. This is outpatient departments. Next slide, please. This slide, I'm just describing the community and primary level where we are providing services. This is the most basic, where we are getting the registers. The data is very, very basic. What we expect from there is just a basic IDSR report, which goes to the secondary level, which we call district. And we have 29 districts. These are manned by senior nurses, clinicians, and others who aggregate data from all health facilities, primary level, and they also create their own report. Next is tertiary, which does the same just for that site. And then from the central level, it is me and others who get for the whole country to create a comprehensive IDSR report. Next slide, please. In this slide, what we're showing is if you look from the red arrows on the left, this is the standard that we would expect under IDSR, that data will move from primary level all the way to the top. But there are parallel lines. The blue one is showing Department of Planning in the same Ministry of Health, which is focusing on HIS and health management information systems. Some of the data is also the same ones that we collect for IDSR. In green, what you're seeing there are national disease control programs. An example is malaria or TB. They also have their own surveillance systems and they collect data from the same sites that I mentioned primarily. In paper, you are seeing an example where externally funded programs or research programs also collect data and they send abroad. All that contributes to data from Malawi about IDS. Next slide, please. In this slide, what I'm showing is that for the sake of IDSR, we chose a certain list of priority diseases where we should focus more. In yellow, you are seeing diseases that have no specific funder, and all of those come under my office for management. Below, you are seeing HIV, tuberculosis, malaria, and schistosomiasis. Each of those has a specific funder. And the reason why I'm putting that is on the next slide. So let's go on the next slide. You'll find that for the programs that have got a good funding source, like the National Disease Control Program on the left below, they have good quality data because the reasons are in the yellow. Versus the top one, which is the Public Health Institute of Malawi, which has low funding for IDSR, our data is usually of the poor quality. The differences come because where you've got good funding, you are able to employ data collectors and other staff dedicated just to pure data. And then we are able to do collection using updated tools. Supervision is also up to the top, and they are dedicated reporting structures. In fact, disease control programs prefer to collect their own data. So on the right, what we're saying, when you have got good funding, you are guaranteed good quality surveillance data. An example is where WHO this year has supported us to keep on producing regular epidemiology bulletins, and this acts as a feedback back to the sites, and they have indeed improved in their timeliness and the quality of the data because of that funding. Next slide, please. The next after this. Yeah, in this slide, it's on the left, the same one, which is showing primary, secondary, tertiary, and national level, the flow of the data. Here, I wanted to emphasize that in all those levels, we have a common challenge of proper definitions, case definitions. We don't have proper. We don't have proper guidance what the sites should be reporting. We don't have in any of those a red flag system. For example, if there's an outbreak, you wouldn't easily find it. And then there are no we need revised forms because we have a generalized form for all levels, and resources guide national implementation and also analytical capacity. All of those are lower. What happens in this case is that, for example, case definitions, you would find malaria control program will describe what malaria cases should look like. The IDSR forms will describe it slightly different. And in the case of malaria, you'll find that somebody will be collecting for all malaria cases. But in the case of malaria control program, they might be focusing on malaria in pregnancy. These are the small differences that we have not clarified. And as a result, sometimes when we're going to do quality cleaning exercises, that's where we discover there was an outbreak here, we missed it. Or maybe there is an ongoing outbreak which nobody actually picked until now. Next slide, please. The challenges.
Sorry to interrupt, Ben. Ben, we need to bring this presentation to a close in a moment. Thank you very much.
This is my last but one. There's lack of collaboration. This is an emphasis. They are not collaborating very well. The IDSR guidance is not good. And paper-based business is a challenge. But we're thinking that there are opportunities like infrastructure. We have good. There are schools. There are internet surveillance systems are available, and the stakeholders are willing to cooperate. Last slide, where we are saying we have the infrastructure now, and then we also have partners where we need support. All we need is more technical support and financial support in order to do more on the IDSR. Thank you very much, Quentin, and all colleagues. I wish I was there in person.
Thank you very much, Ben. I apologize, we struggled with the sound a bit with the last slide, but your slides were really good and we could see the main points. So thank you very much indeed. I think now we're going to Uganda. So, Alex, please. Okay. We could. So I think Mustafa is going to make the presentation for Pakistan. Is that? He's online, okay. Can we go to Pakistan instead then, if that's possible, please? Dr. Mustafa Khan, good morning, or good afternoon, possibly.
It is afternoon. Good morning, everyone. It's a pleasure to be here. I'm presenting on behalf of Mohammed Khan, the Chief Information Officer. He's unfortunately under the weather a bit, so I will be giving the presentation from Pakistan.
Great. And if you could keep it to 5 minutes, please. Thank you.
I will try my best. Is the presentation on? I cannot see. Yes. Next slide, please. After the 18th Amendment to the Constitution of Pakistan in 2010, health came under the purview of the provincial governments. As a result of this devolution, there are a plethora of disease surveillance systems, health information management systems, and lab information management systems operational in silos across Pakistan. Few of the systems are listed here for the understanding of the health ecosystem of Pakistan. We have DHIS1, DHIS2 based platforms for disease surveillance collection. We have lab information management systems. We have vertical programs, which are EMRs for hepatitis, TB, malaria, etc. And we have telemedicine platforms. Next slide, please. So the National Institutes of Health is the designated National Public Health Institute of Pakistan and is a national focal point for international health regulations. NIH is leading the implementation of Integrated Disease Surveillance and Response System, IDSR, as part of the real-time surveillance, a core capacity of IHR 2005. The Ministry of Health in Pakistan came up with the National Health Vision 2016 to 2025. Based on provincial realities, it strives to provide a responsive, unified direction to overcome various health challenges, while ensuring adherence to the universal health coverage as the ultimate goal. In May 2016, Pakistan conducted its joint external evaluation to assess the 19 core areas of IHR at federal and provincial levels. The result indicated 48% level of preparedness in the capacity of surveillance systems to detect, prevent, and respond to public health threats and emergencies. Consequently, IDSR was initiated in Pakistan with the technical support of UKHSA. NIH has recently been reconstituted under National Institutes of Health Reorganization Act to cooperate and manage institutes and centers for carrying out research and for the prevention of the spread of infectious disease and health emergencies in Pakistan. Next slide, please. As we all know, a legal framework is essential to respond to public health emergencies. In terms of legal framework, the NIH Reorganization Act passed in 2021 has given the Center for Disease Control the mandate of declaring health emergencies, making appropriate arrangements for surveillance and monitoring, and issuing advisory on epidemics and disease outbreaks. Similarly, National Health Laboratory is responsible for the establishment and operations of state-of-the-art core laboratories and work as a reference lab for emerging diseases. The National Health Data Center is been established most recently and is critical for IDSR as it has the mandate to maintain a central repository of all health information and data as per the Reorganization Act. Next slide, please. In terms of the provincial level, various acts like the Khyber Pakhtunkhwa Health Surveillance and Response Act exist, the Public Health Emergency Provision Ordinance in Punjab, and the Healthcare Commission Acts. These are, as I've mentioned previously, the mandate for health is now a devolved subject, and the provinces have the mandate. So these are instruments that can be utilized for effective management of disease surveillance and response. Next slide, please. In terms of governance and reporting, each province in Pakistan has established provincial disease surveillance and response units known as PDSRUs. While there are 155 disease surveillance and response units that are compiling data at the district health officer level and sharing this data with the PDSRUs for the inclusion of this data into the national health data stream. This data stream, DHIS2 platform is utilized at the national level to collect and collate data. Next slide, please. So we have identified the 7 key themes for understanding the context of IDSR in Pakistan. These are governance, integration, human resource, coordination, public health labs, IT, and finance. In terms of governance, some challenges we face pertain to political instability.